Elderly patient, what challenges an elderly patient give? So if you just anyone wants to just Hassam, if you are having a patient who is 70 years old, what do you think what will be the challenges you may face? What will be different in a patient who is 70-year old? Yes, anyone wants to say anything? Okay, actually, just like we started pediatric, we will start in the similar way. Okay, so the first challenge you will have that there will be certain physiological, pharmacological, and anatomical changes which will be there in elderly patient. Okay, so what will be that? What will be those changes? For example, if we just talk about respiratory system, what do you think? What is different in an elderly patient? Yes, Jamil.
जी सर, अस्सलाम वालेकुम, I just joined.
Okay, so I just asked this question that if you are dealing a patient who is 70-year-old, so what do you think? What are the different challenges you will have? So if we start with the respiratory system, like you have to tell in practical as correlating the change with the practical aspect. So what do you think will be the change in the respiratory system, and what will be the effect on the anesthesia management?
Uh, Sir, the 70 plus patient means elderly patient, the respiratory changes first will be low chest compliance, and they are more lung compliance, and they are diaphragmatic breathers due to the less chest compliant. And if we decrease anything that now means the diaphragm compliance means increase of intra-abdominal pressure, uh, they immediately desaturate. That's why we have to maintain the good tone of diaphragm if they are spontaneously breathing, or we have to post-operatively consider about the intra-abdominal pressure, because it will also affect their diaphragmatic movement. Second, they have decreased response to the hypoxia and hypercapnia, and due to their carotid bodies, and definitely they will not well respond to hypercapnia. Uh, Third thing regarding lungs, they might be have some other lung diseases like bronchitis, emphysema, or
Would you
might
like
be there.
would you like to say something
Uh,
about closing capacity?
yeah, I two parameters also, and they, yeah, with the age, definitely they increase the closing capacity, and at age of 65, the closing capacity in spine position exceeds the FRC, and definitely it will early collapse the airway. And regarding if now decrease of what is the increase of closing capacity, there is increased risk of
What is
airway
what is closing capacity?
atelectasis.
What is closing capacity?
Closing capacity, how at what residual or volume, or means the function residual capacity volume, when the small airways start to collapse,
Mhm.
and on
So,
expiration.
please say again. It is not functional residual capacity. Okay, mind it. It is not functional residual capacity.
No, no, yeah, sorry, definitely is the separate parameters means that the small at the what you say, the volume at which the small airways start to collapse on expiration
Mhm.
is called
Okay.
as closing capacity.
So, what volumes are there in it?
and closing volume and residual volume.
So it is above residual volume, the volume at which small airway tends to collapse. Okay.
That's
And
correct.
is there any change in FRC in elderly patient?
Uh, yes, most of the times, they have some normal or some increase in FRC with the with advance of age.
As far as I know, there is no change in functional residual capacity. Okay. And closing capacity increase and approaches FRC. That is the concept. Okay. And as you told that
Mhm.
lung compliance, chest wall compliance decrease. What about lung compliance? Lung compliance are also decrease, I think.
The price increase due to decrease of elasticities and elastance or elastic tissue, increase of chest lung compliance.
Okay. So this will be the implication that if, for example, they will be becoming hypoxic early. So you have to pre-oxygenate. And then other important thing will be related to the PO2 will be decreased. Okay. The PO2 gradually decrease with age. Am I right?
Yes, with increase of age, there is a decrease level of PO2 also.
Okay. And what other effects, as we told that the response of hypoxia and hypercarbia gradually decrease. Okay.
Yes, decline.
And so they are sensitive to the, and then moreover, because of the tone of the muscles of pharyngeal and bulbar muscles, they will tend to uh, collapse airway because of loss of elastic tissue. Okay. So this is like another, it will be also related, the practical aspect that because they may be edentulous. Okay. So if they are edentulous, it will be difficult to have bag mask ventilation. It's a risk factor for bag mask ventilation. And what else? Like yes, the other things will be related to they have also mentioned here this vocal cord closure is increase, so decrease cuff reflex. Okay, so practically what will be happening that there will be chances of
Yes,
atelectasis.
but yes, and this causes the silent aspiration in the old patients also.
Yes. Okay. So like if you want to evaluate, okay, so what you should be doing if you want to if you just translate these changes, that how will you you will maybe needing airway during bag mask ventilation. Okay, you need to pre-oxygenate. Okay, you should be careful about giving sedatives in pre-medication. Okay, because the airway may a patient may choke, airway may collapse. Okay, and what else if you just translate into practical aspects, you will
Yes,
be.
and also think about the opioids, long-acting opioids. We have to avoid morphine or other high doses of other opioids because they are definitely more prone to hypoventilation and less response to the hypercapnia. And preferably go for the original if it is possible.
Yes. So that's what I just want to, I want you to correlate between the practical aspects and the clinical aspects and the theoretical aspects. Okay. So what about similarly, if we just discuss about cardiovascular system. So what do you think are the changes? Because actually I want to, yes, first, what do you think, what is different in in the cardiovascular system of elderly patient?
In cardiovascular, sir, but there is a more decrease of sinus cells, means there is a risk of atrial fibrillation and atrial flutter with increasing of age. And the heart rates also, there is a decrease is gradually, and they are poor respond to the means hypotension. There is less means decreased reflex of this baroreceptor reflex,
Hmm.
and
But
their
you use
cardiac
the word fixed cardiac output, heart rate dependent cardiac output.
yes,
Okay. And the
and yes,
reflexes,
do
the
not
baroreceptor reflexes are not as functional as they are in
as in young
adult
patients.
population. So if you are expecting,
And
like what will be the effect that, because if you combine this factor with the more incidence of diabetes and hypertension, uncontrolled or ischemic heart
hypertension,
disease.
yes,
Okay, so what will be the effect that these reflexes will be exaggerated. Okay, so
exactly, yes.
so
If we want to
that's
increase the cardiac output, we have to increase the stroke volume because it's difficult to increase the heart rate. I mean,
yes.
they are less responses to the catecholamines, and
Like
also
I repeat that the reflexes will not be active as they are active in the adults in the
the
young age.
young,
So the
young,
response of the anesthetic medications will be brisk, and there will be sudden change of blood pressure. Okay. And this will also be related to the autonomic neuropathy, which may be there because of the presence of diabetes mellitus and hypertension.
yeah, same like in cardiovascular bed, then increase of systolic pressure, especially the
Hmm.
increase of diastolic pressure, decrease of pulse pressure, and their exaggerated effect of the induction drugs. They have exaggerated hypotension on induction, that we have give the medication on titration, titrated doses,
Okay.
and
So
if
what else? Like if you just correlate it, what will be the effect? Like you told there, what will be the effect of blood pressure? What about systolic blood pressure and what about diastolic blood pressure?
yes, there will be a increase of both systolic and diastolic, but uh, diastolic more, and there will be decrease pulse pressure
Decrease pulse pressure. And why it happens?
due to decrease of again the elastance in the vascular bed.
Okay, so you should be considering this when you are monitoring. And like you said, like we discussed that the compensatory mechanism to change in blood pressure is blunt. Okay, so there is a sudden change in blood pressure. So to counteract that thing, the one thing you told that we should be giving the medication slowly, titrated. Okay, this is one thing. And what is the
Yeah.
second thing?
We have give some titrated doses of vasoconstrictor like phenylephrine and other
No,
drugs,
no, this is
just
this is something else.
uh,
What you should be doing, number one, you should be
yes,
giving
and
titrated
then
doses.
then just and then at time of laryngoscopy.
No, just a second, just go step by step. You should be monitoring intra-arterial blood pressure.
Yeah.
Okay.
Okay. Yeah.
Just
Invasive.
to it is better to have invasive blood pressure monitoring. Okay.
Yeah.
Of course,
Yeah.
you have to blunt the responses as well. But
Yeah.
if you are dealing a patient like that, it is better. You should have a intra-arterial blood pressure monitoring. That will be helping you out. Okay.
Yes.
And you can use a combination of medications rather than giving one big dose of propofol. You can combine it with some small doses of like opioid, short-acting opioid like fentanyl. Okay, you can combine small dose of midazolam that will lead to reduction in the dose of propofol. Okay, because
अच्छा
propofol will have pronounced effect effect on. You see, this is very bad. I would request all of you to mute your mic whenever anyone wants to speak out. All of you are welcome to unmute your mic, to raise the hand. I will be very happy. Anyone participate. Okay, but please mute your mic. Okay, so that's what we were just discussing, that there is loss of elasticity. So there is more chances of development of hypertension. Okay, and SVR is increased, and there will be exaggerated responses to laryngoscopy. There will be sudden increase in blood pressure if you are not blunting it by giving some opioids, or and there is this change in blood pressure. Okay, both systolic and diastolic blood pressure decrease with more effect on diastolic blood pressure. Okay. Any other practical implication of these points?
And yeah, and the other thing, just want to add also, if there is hypotension, we try to manage with the vasopressors rather than big boluses of IV fluid, because the IV fluid infusions, means the bolus is also limited. We can give 8 to 10 ml per kg, not more than that, because heart cannot manage and the kidney also cannot manage rapid.
Jamil,
Uh,
can you speak out with your mic near to your so that
Actually,
your voice is
yes,
clear?
sir. Actually, the signals are very bad here. I am not at home. I am
Okay.
somewhere else. Yeah,
Okay.
that's why the signals are. The mobile data is definitely not very good. I am
Okay.
sitting very corner to that house
Okay.
to streets.
So if you just add on, what else will be the challenges when you are dealing a patient of elderly age? Like,
Other general challenges that the patient first of all have difficulty in IV line insertion,
why?
very fragile, very fragile veins, and there is decrease the subcutaneous
Fat.
means fat.
Okay.
That's why it's not difficult to
So they are easily punctured. Easily punctured.
function.
Okay. So you need to be careful in taking IV lines. What
Yes.
else?
Second thing, most of the patient they have osteoarthritis or very limited joint movements, difficult to make a position for any regional blocks or any other surgeries now. Uh, and third one, if we see, then the patient are prone to hypothermia. These patients are because of less muscular bulk. There is less energy production in this age. And fourth,
Less fat. Less fat
fat.
as well.
Fats also, and the energy, the production of the energy is due to the muscular movement, muscular activity, and
Mhm.
they have less physical activity. That's why it's less energy production. And the other, if we see, then if we go for the central neuraxial block, then also there is some osteoporotic changes on the spine and calcification of the ligament flavum, difficult to insert
So
the epidural.
what are the ways to avoid these problems of regional anesthesia, especially for example, spinal or epidural? What would be the solutions to it? You can use paramedian, okay, because midline ligaments may be ossified, but you may
Also,
find it relatively easier to perform spinal anesthesia or epidural anesthesia with a paramedian technique. This is one thing, and you should be
approach.
using
Mm.
ultrasound to find the midline, okay, and to find the distance between from the skin to the epidural space. Okay. And also you can count the
Yeah.
vertebra. So this will be the change, and this will be the how to manage it. Okay.
Yeah.
So other thing, important thing which is there, that because of chances having visual impairment and deafness, okay,
Yes.
these
Deafness.
patients
Yes.
and
Difficult to
more
communicate.
difficult to communicate. So you may face difficulty in having the preoperative assessment. And another important challenge you will be facing in preoperative assessment is
Post
that
operative. Yeah.
just a second, please. That you will
Coming.
not be able to assess the physical activity because of limitation of the movement because of osteoarthritis. Okay, so you cannot comment on the physical activity. So you might be needing invasive testing. Okay, invasive testing if you want to
Mm.
evaluate the patient. Okay, and then because of this deafness or visual impairment, this is a risk factor for delirium, post-operative delirium. Okay, so you should be taking care of the temperature. You should be taking care in taking IV lines. You can face problem. You should be very careful stretching the skin, making the vein prominent, and try not to double prick it. Okay, and uh, uh, other things we also discuss. I'm just trying to correlate the changes with the practical aspects, because then you will not forget it. Okay. Okay. So, what are the diseases which are prone to occur in geriatric age group? More
Diseases are
chances. Yes.
more chance of hypertension, cardiac
Diabetes,
disease like hypertension, heart disease,
hypertension,
cardiac
diabetes. What else?
diabetes, and if starting from CNS, there is a rise of Alzheimer and
Okay.
dementia. And if
Try to
we
try to tell the things which are more important to you. Okay. Like if you talk about
Mhm.
diabetes and hypertension and
Cardiovascular,
ischemic
yes,
heart
then the
disease.
best will go for the respiratory. Then will be more chances of they have a respiratory disease like emphysema, COPD, or most of they have uh,
What else? What about
mm,
renal failure?
yeah, they
Okay.
also physiologically have declined the function of kidneys
Not only
and
physiological decline, there are chances of benign prostatic hyperplasia, which is a risk factor for development
yeah,
of hydronephrotic renal
obstructive
failure.
nephropathy. Yes, they have also chances of an obstructive nephropathy, increase of urea creatinine, and also the kidney also poorly handle the IV fluid also, and what do you say there is also maybe you will find some disturbance of electrolytes in this elderly age.
Okay. So, anyone else wants to comment anything, please? If you have missed anything, all of you are welcome to just comment, because you see all these things are written, but I'm just trying to correlate the theoretical aspects with the practical aspects. Okay. So problem of mask ventilation, edentulous airway, problems of IV lines, careful.
Yes, neck,
The
neck very
chances
important
of
to find
having
about
swings
the
of blood
process.
pressure, intra-arterial blood pressure monitoring, and titrated doses of induction agent. Okay. Then use of medications which have less metabolism. Okay, because the metabolism is also slow. Renal excretion may be decreased. Okay, and then avoidance of long-acting opioids, which can cause post-operative respiratory depression. Okay, but at the same time, you should have a good pain relief, because if the pain relief is not good, patient will have already chances of atelectasis, and because of impaired cuff reflex, patient might go in Yes, sorry. So these things you will be taking care of. Okay. Just we will just try to. Okay, one more similar to the diseases we talked. What are the surgical procedures which are more common in elderly patients?
If we, in the routine practice, then there mostly is, the orthopedic surgery, like
Orthopedic fractures,
yes,
the
fractures.
fractures and joint replacements. Okay.
Yeah,
Among the fractures, which is the most common? Neck of femur fracture, neck of femur. Okay.
neck of femur.
And they have chances of frozen. They like it's not clearly, but they also come for actually a short procedure because of this frozen shoulder uh, manipulation. Okay. And joint replacements. So these are related to orthopedic and other urological procedures like this TURP. Okay. What else? What sort of procedure?
Urological there is more risk of malignancies, like related to malignancies of the
Otherwise,
bladder.
otherwise, any procedure can occur. You are missing. I'm just trying. This is a vision. This is just impact of your critical thinking. They are for eye ophthalmic. This one cataract surgery. Okay, cataract surgery is one of the most common procedure in elderly patient. Okay, if they have no other problem.
Hernias, sir.
Hernia, yes, obstructed hernia, okay, or like inguinal hernia because of decrease of muscle tone, okay, hernias, yes, you are right. Then what else? Okay, so these are the because in our next discussion we will try to discuss common procedures and how to perform them. Okay, about these elderly patients. Okay, so just a second. Uh, I will I will suggest you to have a look on this perioperative care of elderly. Okay, and you will find most of the important things over here. Okay, for any guideline, because sometimes these guidelines are very long ones and people are afraid of by the page number of pages. So usually you just need to have the summary and the recommendations. Okay, so just whatever they have recommended, the main recommendations will be the one which you should be focusing on. Okay, so okay, so just a second. We will just try to have a look on what they have mentioned here. Majority of the things we have already discussed. Um Anemia is common. I don't know. They are saying anemia is common. I don't know about it. Musculoskeletal problems. Yes, another surgery which is
Yes,
there for.
anemia also common due to the decrease of nutrition.
Sorry.
Yes, anemia also common. Somebody if this mentioned, that means he's right, because this age also decrease of nutrition supplements, and there is chronic anemia also, iron deficiency anemia.
Okay. Okay. So like we will just finish our discussion on this note. We will continue our rest of the elderly system evaluation, and I just left evaluation for the next discussion because we will just get an example of any disease surgery and we will proceed. Yes, Dr. Linas Al Sadiq. Do you want to say something? Okay, any other comments or any other questions? We will continue our topic, inshallah, next time. Okay. I will share this recording, as well as I will just share the link for this geriatric folder. So I will suggest you to have a look, and we will continue, because geriatric
Yes,
population.
excuse me.
Yes, yes.
Anna, I'm asking you from which age I can see this is an elderly patient.
Very nice question. Because actually
yes.
the definition of elderly patient is different in different population. Like if you are talking about West, because there is more life expectancy, they say a 60-year-old, they according to them is middle age. Okay, they say usually more than 80 or more than 70 years they say elderly. So it's a relative terminology. Okay, for a Pakistani, for example, we'll say 60 as an old age. So there is no universal. Usually, if you just follow this guideline, I think they tell as more than 70, if I'm not wrong. Any comments on it? I think it is more than 70.
On exam, if they said to me 60 years, I will set it as
Sir, in Oxford, it is written 60.
Yeah, yes, just a second, Usman. Yes, Dr. Lina, what you're saying?
60 years old.
Okay.
I
Yes,
consider
Usman.
it,
Okay, Usman, sorry, please now tell.
Sir, yes, sir. Sir, in Oxford Handbook of Anesthesia, it is written elderly as referred to the patient more than 65 years.
65. Yeah, you see,
65.
you will find different age group. You can say, if you want to answer in a smart way, that in different races in different countries, it may be a little bit different. Okay, usually it is more than 60 or 65 years, but some in West they claim at more than 70 as geriatric. Okay. Okay, anything else? Usman, you want to ask anything? Comment anything?
Sir, fine, sir.
Okay.
And
so
sir, the reason
yes.
for anemia is, sir, the reason for anemia is written that it is the response of marrow that is impaired in towards anemia in elderly patient.
Yes, or there may be, you can correlate it with the number of things like they have written. It may be because of renal failure which developed. It because of maybe I have not concentrated before about this thing. Usually we target more hemoglobin in these days age group, because if there are chances of if there is some coexisting cardiac problem. So in that way, anyways, you need hemoglobin more than 10. Okay, so okay everybody, thanks a lot for your presence, and I will share the link for this Google Drive link. So I will suggest you people to have a look, and we had some sessions before for geriatric. You can have a look on that as well. So inshallah we will continue next time.